I've decided to talk about the urban poor, basically because of some of the experiences I've had working in Africa and working particularly in some of the poorest areas in the slum communities. So I start off by just highlighting the problem as I see it, and then later on I'll tell you about some of the motivations, how I got into doing this type of research. So the biggest problem I think we are having in the African cities is one, rural to urban migration, but also accompanied by natural population growth in the cities because fertility is quite high. But this is leading to large population increases in the cities and in the towns. But unfortunately, housing and social services, they're not keeping up with the population increase. So you have a situation of large overcrowding, very poor sanitation, no garbage disposal systems, no sewage systems, and then accompanying that you have insecurity, and particularly women and young girls vulnerable to sexual violence and things like that. So there's quite a lot of risk-taking health-wise, so for example, sexual risk-taking, resulting into poor health. But then you've also got issues to do with infectious diseases, diarrhea, and the likes. With any migration, you have to think of the things that push people as well as pull people. So some of the push factors in the rural communities of Africa, it's a hard life. And you're looking at huge population pressure brought about by high fertility levels in the rural communities. And you're also looking at real poverty in the rural communities. So the thought of going into the cities is always attractive for rural people who are facing hardship and having to make a living out of maybe cultivating the soil or cutting down trees and the like. So usually they're going into the cities in search of a better life, and I've got a picture there where essentially you're looking at a quite well-planned city. This is a picture from a long time ago, one of the cities, it might be Nairobi, but essentially the thought is a city where everything is nicely planned, you have better housing, you have schools, social services, healthcare, etc. And these are some of the reasons that people give when you ask why they migrated, say, from villages to the urban centers. And in some places, in some cases, they also talk about being able to have funding to help the rest of the family back home in the rural communities. The reality is often, I don't know if you can see the pictures as well there, but the reality is often overcrowding, and the left-hand corner there is a picture of Kibera, one of the larger slum communities in Africa, that's in Kenya. And you have situations where, essentially there are no toilet facilities. As I said, no garbage disposal, people are just throwing rubbish about. So that's a situation that most people who are migrating from rural areas into the cities find themselves in. So what I would like to now do is just to say a little bit about what got me started to start looking at intra-urban health. I'll talk a little bit about the growth of urban population in Africa. And then I've got 3 examples that I would like to illustrate looking at the health of the urban poor. One is to do with maternal health, so looking at motherhood. Another one is to look at child survival in cities. And then the last example I have is looking at HIV infection. Being a social scientist and demographer and statistician, my sort of research areas are very eclectic because I'm attracted by numbers and being able to look at patterns, so I dabble in a lot of things. So that's a reflection of my research and my life. I'll finish off by just saying a little bit about some of interventions and challenges that I faced in doing that. So what got me started, as I said, I'm a number cruncher, and I was actually looking at data from Zambia. So we're looking at around 1997, 98. I was looking at data from Zambia and looking at child survival with those data. And I knew that Zambia had been going through quite a difficult economic environment. And I did wonder whether, that was actually being reflected, for example, amongst the urban poor. Because up to that point, my way of thinking about poverty was rural poverty, and never really thought so much about people in the cities and facing hardship. But I did some analysis and found this interesting interaction where I was looking at two groups, urban children and rural children, but then I cross-classified looking at household wealth, looking at those with low wealth in the city and in rural areas, medium wealth and high wealth. And what I found was that the ones in urban areas who had low wealth or the low socioeconomic group, they had the highest rate of infant mortality, much higher than even the rural poor. So that's what got me started in thinking about the intra-urban situation and being able to segment the population that way. The rest of the world is perhaps more urban than more urban than rural, but Africa is still lower, has a lower rate of urbanization compared to, say, Asia or Europe. So the urbanization rate for Africa is around 37%, although the projections by the UN are that by about 2030, the African population will be half urban and half rural. So the diagram there just showing you where the cutoff is likely to be around 2030. At the moment, still more rural people than they are urban. The rate of growth is quite high, so the average rate of growth is around 1.4% for sub-Saharan Africa, so south of the Sahara, excluding countries like Egypt, Morocco, etc. I think only countries like Zimbabwe have negative urban population growth, annual population growth, where people are migrating out of the cities, but the rest of the countries have positive annual growth rate. And in some countries like Rwanda, you're looking at close to 4% annual growth rate. So take an example of Nigeria, where the urban growth rate is about 1.9%, nearly 2%, and a city like Lagos with more than 17 million people, every year you're having more than 333,000 people into the city. So that's a big people movement being added to the city every time. And just to stress again that it's not all migration from the rural areas, but you're also having people who are in the city who are having children and contributing to population growth that way. So insufficient housing, insufficient facilities, and sanitation. Just to give an example, this is a map I took from the UN website, just showing the proportion of the urban population that actually reside in slum communities. So the red are essentially the slum dwellers, and then the yellow colored are the non-slum dwellers. And then the size of the bubble is reflective of the population size. So the smaller the circle or the bubble, the smaller the sample size. But as you can see, there are a lot of reds there. So a lot of people actually in urban areas are living in slum conditions. Okay. The UN Habitat has a definition of slums, but it's sort of like quite a loose definition, because if you just don't have, for example, if you don't have a toilet that's within the household, if you don't have a security of tenure, any one of those, if you don't have access to water, etc., then you're defined as slums. So countries like, for example, Ethiopia, nearly everybody who is in urban areas is considered as living in slums, when we know that that's actually not the case. So the definition perhaps needs a little bit of working there. Okay, so the first example I have, which is motherhood or maternal health, and I start off by arguing that it's really a balancing act, and it's not just in urban areas, but I see motherhood as being quite a challenge in most of Africa. So pregnancy is not always a joyful occasion. There are a large number of women who actually would like to delay or stop childbearing who actually are unable to do so. So when you think about the proportion of women who actually don't have access to contraception when they would like to delay childbearing or prevent it, you're looking at close to a quarter of women. So a third of the pregnancies are unintended. And the consequences of that sometimes women, don't use antenatal services, don't use proper delivery facilities for various reasons. Sometimes they're sort of like trying to ignore the fact that they're pregnant, or indeed they're in a place where this is quite difficult. It's quite difficult to get the services. So quite a large number of women facing death and their children also at risk of dying. As an illustration, just to show the severity of, say, maternal mortality in Africa compared with the rest of the world, an African woman from sub-Saharan Africa has 1 in 16 chances of dying, as a maternal death, bearing in mind also the fact that they have high fertility, so the chances of dying are actually magnified because it's not just a once or twice. Some of them are having 4 or 5, some even 7, 8 children. Compared to South Asia, we're looking at 1 in 43, and then about 1 in 4,000 in industrialized countries like the UK, Sweden, and the like. So between 2004 and 2007, I took a sabbatical and went to work in Nairobi with the African Population and Health Research Center, which is a Pan-African research institute that focuses on doing urban research. So they have a surveillance system and they collect data in the slums and demonstrate the plight of slum dwellers to policymakers and the like. So we had funding from the World Bank and also Wellcome Trust to look at maternal health in 2 slums in Nairobi City. And we're interested in looking at barriers to institutional deliveries, but also trying to understand the causes of maternal death in the slums. And then the third thing we're interested in looking at is the health facilities and their preparedness for emergency care. So just a little bit about the surveillance system that the African Population and Health Research Center does. They actually have surveillance for about 60,000 people in 2 slums. And the area, the geographical area is quite small. We're looking at, not far off from about 1 square kilometer with a lot of people staying in those areas. And there are quarterly visits to the houses. And every quarter you go and record who's come in, who's gone out, any children who have been born. And if there's a death, then you do a verbal autopsy. I'll say a little bit about that. One of the slums has about 74% of the inhabitants who are migrants, and the other one is quite a migrant population. 95% of the people there are migrants. The majority of the migrants are from rural areas, and the remaining are migrating from one slum to another. And some of them are, for example, refugees from Rwanda who've come and settled there, or from the Sudan. The majority of people migrate as teenagers, in 15s, 16s, 18s, 19s, all young adults. Okay. So it's quite rare to see people migrating into the slums ages of 40, 50, etc. Usually they tend to be quite young. And employment is a problem. About 14% of the population under surveillance are actually in salaried employment. So majority actually are doing casual work or self-employment. Just to give you a picture, that's a population pyramid for the 2 slums And what the pyramid shows essentially is what I've been talking about, the fact that you've got in-migration at younger ages, working ages around, say, 20, 24, all the way up to about 30 to 34. And then you also have absence of the older generation, because people, when they've retired, they tend to migrate out of the slums, usually back to their villages. Okay, so with the maternal health studies that we were doing, when we identify, say, a day that a person has died in the community, and if they are a woman of reproductive age or a young girl, then verbal autopsies would be done. In fact, verbal autopsies are done for any death, so even with males and etc., trying to identify the probable cause of death. And usually it's two medically qualified people, and if there's disagreement, you have a third person to sort of like confirm. With the female deaths, we decided to examine again all the maternal or the deaths between 2003 and 5, just to check if they'd been missed as maternal deaths, because with the definition of maternal death, it's quite broad. You're looking at a death to a woman who's either pregnant or immediately after birth, after the birth of the child, up to about 6 weeks. And sometimes it's easy to miss some of these pregnancies if they've just died suddenly in pregnancy. It's possible to miss the deaths. So we reviewed the female deaths aged 15 to 49. We also interviewed women who'd recently given birth, just to find out about their experiences of giving birth and where they'd given birth, so that we could actually identify the facilities where women were giving birth. So when we looked at the maternal deaths, we actually found that in the slums, maternal mortality was about 25% higher compared with the rest of Kenya. So there were roughly about 290 deaths to women, of which 10 were maternal deaths, 10% were maternal deaths, i.e. 29 deaths. There were some late maternal deaths, women who died after the 6 weeks, but then, they were not classified as maternal deaths, but could have been maternal deaths, just that their deaths were delayed outside the cutoff period. So about 606 deaths per 100,000 live births was what we estimated as maternal mortality rate in the slums, and the national rate was about 560, just showing quite a large difference. And during the survey that we did, interviewing the nearly 5,000 women, about 70% of them reported that they'd delivered in an institutional delivery, i.e. at a health facility or a hospital. But then when we actually went out to see these facilities, we found that quite a large number of these facilities were actually not health facilities. One, they were not registered, and most of them were like a business. So person, with just basic, information about health, bought a white coat, was called a doctor, and then they provided, maternity services. So the real percentage of true institutional deliveries, we estimated to be about 48%, rather than the 70% that we'd been told. And then in terms of what the women were dying of, the health facilities that we actually visited, there were about 25 of them. There were the facilities that the women in the slums had said they delivered at, and 2 of them were large hospitals owned by the state, Kenyatta and also Pumwani, which is a specialist maternity clinic. And some of them were registered, small facilities registered by the Ministry of Health. The rest were sort of like, as I said, businesses. So when we're looking at the health facility data, we're looking at records that actually were in the facility, and some of the women were not slum women. And then with the community data, this is data that we actually looked at using the verbal autopsies to try and establish the cause of death. Okay. So just a bit of a comparison, we found that with the community data, we were able to identify about 31% of the deaths being attributed to abortion-related complications. And when you take into account the fact that abortion is legally restricted in Kenya, it's not surprising when you get to the health facility and you find that it's only a very small percentage, about 7% of the deaths scored abortion related. But working in the slums, there was no doubt in my mind that there were a lot of abortions that were actually taking place, illegally within the communities, and the complications that sometimes led to death. So, and again, also, for example, in the communities, we identified about 14% of the deaths being related to HIV complications or HIV morbidity, whereas in the health facility, it was only about 3%. So just again to emphasize that the people in the health facility, or the statistics there, relate to more than the slum community, while as the community data were just the women that were identified in the slums. But essentially, there's quite a lot of deaths that are happening through infection or hemorrhage and preventable conditions, I should say. Okay, in terms of preparedness for emergency obstetric care, of the 25 facilities, 2, as I said, were outside of the slums, and they were owned by government. And we looked at staffing, we looked at the procedures performed, we looked at the equipment, the supplies, the referral system, also looked at the health management information system. And only 2, the government hospitals, met the criteria for comprehensive emergency obstetric care. Most provided less than basic care. So when we use the basic care, criteria, majority of the facilities didn't even meet that. So essentially, we are in a situation where these poor women are actually going into facilities where, when something is wrong, there isn't really the support or the care to help them. So next I move on to children. So what about children? So I'm using the slum inhabitants and rural urban migrants, sometimes interchangeably, but I know that sometimes the slum inhabitants have been there for a long period of time. But the slums are the first destination of the rural urban migrants. And in doing this work, we actually looked at a number of data sets. We were interested in looking at, urban advantage of children in Africa using data from many African countries, but we were also using the Nairobi slums as a case study just to look at what was happening to the slum children compared to children outside of the slums. So the first study there was a study that I conducted with 2 colleagues. It took a long time because it was unfunded, so it took 5 years to do, because essentially we worked on the paper every time we met at the conference. So that's not a way to do a paper, but I would like to think that it ended up being a 3-star, at least, paper for ref. Anyway, the data came from 18 countries in the 90s. Again, because we started it a long time ago, that's why it's older data. But looking at the data, and these are national representative data from 18 African countries, migration is quite high in the rest of Africa. It's not just in Nairobi. We're talking about most of Africa. And it's not even just, urban rural migration. There's also quite a lot of rural to rural migration. People move a lot. So 35% of the urban mothers lived in rural areas before, and 26% of the mothers in the rural communities had also lived in urban areas before. And there was quite a lot of migration within rural communities and urban communities. And some of the migration was happening during childbearing years, so it wasn't just the rural to urban, younger, and then urban to rural, older. Some of the migration was happening during childbearing years. And we're interested in the movement of the women, bearing in mind the fact that usually the under 5 children co-reside with the mother. So if the women were moving from one location to another, we took it that the children were moving alongside with them. Countries like Gabon, with quite high movement of people into the city for temporary work and then going back to the rural areas, you have quite a large proportion of children who live away from the mothers. So in the national surveys, and these are demographic and health surveys that are conducted in most of the African countries and Asian countries and Latin America almost once every 5 years, you do have some nice questions that can help you reconstruct where people were at times when deaths were occurring. So there are questions like, how long have you been living continuously in this place of residence, whether it's a rural or urban area? And also questions like, just before you moved into the city, where did you stay? Were you in a rural area? Were you in a town? Were you in a countryside, etc.? Using these two questions, we're able to identify 4 groups of women and their children: those who'd always lived in urban areas, those who always lived in rural areas, those who'd migrated from urban to rural areas, and those who'd migrated from rural to urban areas. But in addition, we could also look at mortality experiences of families before they migrated. So during the time they were in rural areas before moving into urban areas. And once they moved into urban areas, what was the mortality experience for their children? So just starting off by comparing rural to urban migrants, comparing them with those who never moved. So comparing them with rural inhabitants who'd never moved. We're using under 5 mortality rate, which is the death to children before the 5th birthday out of every 1,000 live births. So on average, rural to urban migrants for these 18 countries, you can see that before migration, the mortality rate was about 170 deaths to under 5 children for every 1,000, comparing it to 176 for the non-migrants. So essentially, you're looking at a situation where the migrants were healthier compared to the non-migrants before they'd even moved, which supports the hypothesis that migrants tend to be a select group. They're usually healthier, sometimes they are more educated compared to those who never move. But then when you look at the country-specific analysis, essentially you're looking at 11 out of the 18 countries where the results were statistically significant. So just to give an example of Benin, under 5 mortality for the migrants before they moved was 114 compared to people who never moved in the rural communities, 182. So quite a big difference there. And then following these same families, when they actually move into the into the urban areas, into the cities, so what happens to them? So essentially we found generally lower under 5 mortality after migration. So 122 compared to before migrating, 117. But when you're looking at country by country analysis, we only saw significance in 6 out of the 18 countries. Okay. So there was the general direction was that under 5 mortality was lower when people moved into the city compared to before they moved, but it wasn't significant in all of the countries. And then the other comparison is looking at the migrants into the cities compared with the people who've always lived in the city. So on average, we found that the rural to urban migrants, after they'd migrated, their mortality, under 5 mortality rate was 121 compared to 116 for the urban non-migrants. So slightly higher under 5 mortality for those who are moving into the city compared with those who'd always lived in the city. However, there was a mixed picture. So in some countries, we found that migrant children fared worse than non-migrants in the cities. In some countries, only for about 4, migrant children fared better than the non-migrants. And then in 6 countries, there was no difference. Again, it really depends on the settings, because sometimes people are moving into the city and the situation in the city is not as bad as, for example, in the Nairobi slums, who I've shown you pictures, and then you find that, the migrant children actually, coming into a place where they're already healthier and they're doing well compared to non-migrants. In some cases, it's worse than the inhabitants. And then the other group, which is interesting, is people who are actually moving from urban to rural areas. And bearing in mind that we're looking at under 5 mortality, so you're looking at families who are still in their childbearing ages. And we had to think about who actually moves from cities to the rural areas before they're old, i.e. in the childbearing ages. And our thinking was that these are people who've actually failed to make it in the cities. They're usually poor and then are actually escaping something in the city or escaping poverty in the city. So urban to rural migrants, before they migrate, we found under 5 mortality was about 162 compared to 116 for non-migrants. So those families who are migrating from urban to rural areas actually have higher mortality than the people who are, staying in urban areas, non-movers. Okay, so it's a sort of like a select group with poorer health conditions who are moving out. And after migration, their mortality was sort of like slightly lower, 160 compared to 162, but not, statistically significant in majority of the countries. So there was a picture of improvement in child survival when these urban to rural migrants move, compared to when they were in the city. But the sample sizes we're dealing with were quite small. So not a lot of people move out of the cities back into the villages, but of those who do, they tend to be people with poor circumstances, economically as well as poorer health. Okay. Working at the African and Population and Health Center, we had an opportunity to actually do a cross-sectional slum survey. So instead of just looking at the 2 slums in Nairobi City, we're also able to actually do a survey in 7 or 8 other slums in the city to actually calibrate the surveillance that we're doing. But that also gave us the opportunity to be able to look at some indicators at a much bigger scale. So the data that we were able to collect, we actually could make comparisons. So the graph I have there is just to show the under 5 mortality of children in the slums compared to the rest of Kenya. So we have on the extreme right there, we have the slum children, and then we've got in the middle Nairobi City and urban area, and then the rural areas. So for rural areas, urban areas, Nairobi City, we were using national representative data that collects information for each province, for Nairobi, as well as for the rural areas. And we were able to calculate under 5 mortality rates for different periods in time. And making the comparison there, you can see that in the urban, in the Nairobi slums, you're looking at quite high under 5 mortality compared to the rest of Kenya. So to start with, before the 1990s, in the slum community in Nairobi, under 5 mortality was slightly lower than in the rural areas. So those are the blue bars for Nairobi slums compared to rural areas. But then over time, you're seeing a situation where in the slums, mortality tended to be quite high. So around the 1995 period, which is a time when I think there was quite a lot of immigration into Nairobi City, a lot of inhabitable conditions that people were living in, under 5 mortality was quite high. So by doing this analysis, we were able to document and show, especially to the Kenya government, how the situation of the urban poor was panning out. We did get some, funding, for example, to help. I remember once we got money from the Norwegian government and the Danish government to erect toilets and to have showers in the communities, but there were also challenges with those interventions. I'll finish off with that in a few minutes. just to say how difficult it was to put up toilets and showers in the communities. Final example is HIV/AIDS, and the reason why we came to doing HIV testing in the slums, two things. First of all, some of my colleagues at the African Population and Health Research Center actually documented quite high sexual risk-taking amongst the slum residents, particularly early sexual debut, with children starting having sex at quite early ages, and quite a lot of sexualization is the word I want to use. Quite a lot of that, sometimes because of the proximity, the way people live, mother, father, and the children, they stay in the same room, they sleep in the same room. It's quite difficult to have, privacy for the family, for the parents with the children around there. But then also amongst the married women, there was quite a lot of partner exchanges, sometimes happening as a way of earning additional money to help with the children. So married women in the slums, they were 3 times more likely to have multiple partners compared to, for example, rural women who were married. So all these things made us think about looking and trying to understand how such risky sexual behavior was influencing or affecting HIV situation in the slums. And the second thing was that everybody that we were talking to about the situation in terms of health and all that, they kept saying, oh, you've got to look at HIV and AIDS because that's a confounder. Everything you look at, you've got to think about HIV/AIDS. And then people were just plucking numbers from the air and saying, oh, it's 50%, it's 70%. So we thought, why not just do a proper study and find out what's happening? And we got funding from Rockefeller Foundation and also Wellcome Trust to just do a simple prevalence study. The fact that we had a surveillance system meant that we could actually take a random sample of men and women and actually do testing. So we were not able to find all the people that we wanted. We found about 72% of our random sample for women, and of those, 77 accepted to have the test. For the men, they were a bit more elusive, I suppose because most of the times they were out working. We were able to contact about 67% of the men, of whom 79% accepted to have the test. And then what we did was then to compare the results when we got them with the overall Kenya data from the Demographic and Health Surveys, where they'd also tested about 7,000 women across the country, and they had about 72% rural people, about 6% from the Demographic and Health Surveillance were from the slums we worked out. So HIV testing, and the results, as we expected, we found that in the slums, HIV was a lot higher than, say, in non-slums in the cities, as well as in the rural areas. So, for example, for women, we're looking at more than double the national rate. So national rate was around 6%. For women, we're looking at about 13% of the women in the slums, aged 49, were HIV positive. So we're looking at about 2006 to 2007. That's when we did the study. And then also similarly for men, there was a quite higher HIV prevalence compared to men in non-slum areas as well as in rural areas. So this was the first study that actually did a prevalence study in slum communities, and we were able to document the much higher prevalence compared to the rest of the city. So it's not easy to unpack what is the reason for such a high HIV prevalence in the slums, but it's not all about wealth status, because after you account for the place of residence, we didn't find an association with wealth HIV status and wealth, we didn't find it, nor with highest education. Sometimes people have said, okay, the wealthier, they are more likely to be HIV positive, but once we'd controlled for place of residence, we couldn't find that. But we did find a strong link with things like ethnicity. In Kenya, there are different ethnic groups with different cultural practices, and that was also shown in our results. And also with when, especially girls, when they had their first sex. So early sexual debut was linked to high HIV prevalence. So that's just a graph showing you the odds of being HIV positive by age at first sex, with those who were had sex at 20 years or older, much lower prevalence compared to those who had sex before 15 years. There was a small percentage of teenagers who had never had sex but who were HIV positive, presumably some of them from mother to child transmission. Okay, so finally, I just wanted to talk a little bit about interventions and also talk about the challenges. I start off by, I've got two slides here. I start off by just talking about what we know works in the slums. So I don't see this as something we need to do research about. So things like governance in the slums and things about provision of infrastructure, I see them as given. You only have to look at the situation to see that you do need to improve the lives of people there. So one example is a slum upgrading where governments and their development partners are helping in terms of doing slum upgrading. The challenges there are that sometimes there's no consultation with residents of the communities. So you find actually people accepting the houses, and then they put tenants in the houses, they go back to their original shacks, and then they're getting money out of them. And then this is also a true story. I was driving one time, we were with colleagues driving in Mpumalanga in South Africa to go to a surveillance site in rural South Africa. And we drove, and I found, by a hill, lots of toilets. And I didn't know there were toilets, but asking the driver, I said there were toilets. There were just lots of toilets by the hillside. And I was like, how strange, why are there the toilets? Where are the houses? And we drove about 10 minutes and found the houses. So that's just an example of, where, there's no consultation, government is trying to help, they build these houses, but then the toilets are, half an hour's walk to actually get to the facilities. The other thing is the issue of security of tenure to prevent evictions. A lot of the slum people, they actually have no tenure, and sometimes they come and build houses where they are not supposed to be houses, so the land belongs to other people. And sometimes also people are taking advantage of the fact that they are poor, they have nowhere to go, they're charged exorbitant prices, and then they get evicted very easily. And the provision of services, water, toilets, etc., these are important. The challenges we found was that we got money to actually build toilets, we got money to build some showers, but then we couldn't find land where we could actually put these facilities because no one really owned this land. It probably belonged to the government or the city, and nobody would give permission. But then also, once we found land that the chiefs within the slums were able to provide, people were reluctant to have the facilities near the chiefs' places. So there was a lot of going backwards and forwards where you have the facilities and the money to help build toilets, but there's a lot of going on where people are reluctant to allow the facilities to take place there. We also had this naive idea that I would have this as a business for women where they could charge the inhabitants to actually, use the facilities. But then within their own slums, they decided that wasn't what they wanted. So eventually they ended up giving the facilities to youth who then use the facilities to charge people to use them, and then they use the money for school fees and things like that. So lots of issues that come about with some interventions. And finally, we've been doing some interventions essentially in terms of promoting healthy behavior. So a number of things that are happening in the slums. One is happening with help of the German government and others, which is reproductive health vouchers, where essentially women buy a voucher at a very low cost, but then the voucher enables them to actually get either contraceptives or to use for delivery when they need to. So these vouchers are seen as quite important, but they're actually operating on a small scale. It's quite difficult to imagine providing vouchers to millions of people in the slums. And a paper by Jessica Ameda from the African Population and Health Center shows in the Nairobi slums, there seems to be some positive effect in terms of use of maternity services, but it's not really as large. So for the subsequent childbearing, once a woman has had a child, the next child, there's some positive effect in terms of use of maternity services. And then we've also just finished our work where we've been working with community health workers who've been giving counseling to pregnant women, and counseling them until their babies are about a year old to promote exclusive breastfeeding. And the results we're just analyzing them essentially. We started off from a baseline of about 2% of the children who were exclusively breastfed, and the results suggest that the prevalence has gone up to 50% in the intervention group, but so has in the control group. So we don't really know whether it's our intervention or something else that's been happening outside that. So we're still trying to unpack that. But we did identify the challenges of actually doing something like this, promoting exclusive breastfeeding in a place of abject poverty where women don't have maternity benefit. Essentially, they are working on a daily basis, and if they actually stay home to breastfeed, that means that's a day's wage lost. And the challenges there, we just discovered that we can't just bring a promotion, a health promotion, intervention like that without thinking about the economics of living in the slums. So quite a lot of challenges that we identified. So I just want to thank you for your audience and for listening.